Now, here's the new concept. Well, it's actually not a new concept. It's an old concept that now has its own code. Notice the 90785 has a little plus in front of it, and that means it's an add-on code. That means that this code gets added on to some other thing that you are doing that day. And add-on codes can only be used when there is a psychiatric service provided from the 9O family. You can't use interactive complexity on an E&M visit alone. So if all you're doing is a 99203, I can't add interactive complexity. If you do a 99203, start a little psychotherapy for 19 or 20 minutes, and that patient is interactively complex, I can add that interactive complexity. You heard me say that interactive complexity is a state of being. Okay? It is not about time. It is not about my being deaf. It is not about my speaking a foreign language. Because one of the things that CMS, Medicare, has cautioned all physicians on is not using interactive complexity just because you're using a language interpreter or you're using a deaf interpreter. They want that interactive complexity to be because of the additional psychiatric issues involved. Many of the patients who are deaf, they also have other components of interactive complexity. Many patients that have a translator may have other components that make them complex besides their language. But we have to make sure that's documented. So that one of the things that you need to go back and think about over the next few months is how are you going to make sure that interactive complexity is documented. It is an add-on code to the diagnostic assessments, to the psychotherapy codes, to the psychotherapy and E&M codes. It can be added to group therapy. It cannot be added to family therapy. It cannot be added to crisis intervention. And it cannot be added to an E&M service alone. Okay? It's only when there's a 9O code. So what is this animal? It is a bunch of things. How many of you here see patients that are children? Okay, so what happens with every child that you see? There's a mom or a dad or a foster mom or County Protective Services. There's some other third party involved. How many of you see angry, hostile patients that are in denial, that are just not in tune with what's happening today? You all do. I was a social worker way back when. And if interactive complexity had been on the radar, I could have coded that with just about every patient because I worked in a hospital emergency room. And they were all angry, in denial, or their family members had discordant behavior, and they were screaming at me. So that it is a state of being. Okay? So it's difficult communication with a discordant patient, okay? Or emotional family members. That patient that you've got, that you're working with, and the family's in denial, and they're interfering with that plan and process. Just interactive complexity. The patients with maladaptive communication, anger, hostility, verbal impairment, underdeveloped in children, okay? Or someone who's had a stroke, or someone who's having any kind of they're catatonic and they're not communicating. And then we have the third party involvement in the caregiver process. It might be a parent, a legal guardian. How many of you see patients from the court system? And you're talking to the probation officer, talking to that correction process, interactive complexity. Those of you who are dealing with special programs, maybe school programs or adult programs. So that's interactive complexity. And the reality in some of your populations, if you're doing psychotherapy with your E&M, would probably be using interactive complexity at a high level. In children, the expectation is that it would be probably close to 100% of the time. Though one of the psychiatrists I work with realized that as some of his children age, and he's no longer involving the parents in the plan, like a 16 or 17-year-old, they may no longer have interactive complexity. But most of the kids, especially like 12 and 14, those that are involving other folks, that would be appropriate. Last evening, I had an email from one of my Suboxone fellows and said, was this interactively complex? He had a patient who is in their active recovery program that brought a friend with him to be educated and to be involved and to be his mentor on his recovery program and to talk about that interaction and process. And the answer is yes. Even when that patient brings someone themselves to be in that process for recovery, but we have to make sure we document, one, who that person is and what that role in the process is. So it may be third parties that are legally responsible, might be foster parents, it may be County Protective Services, it may be my guardian, it may be my parent. It may be things that are the request of the patient or the process of the patient. It may be a required process. Okay? Somebody that is there always with a caseworker from an outside agency because of whatever's going on with that patient, like in a group home where they're coming in with that patient to assure recovery. When CMS identifies that, I have to make sure that we document it. What that maladaptive communication is. So you might want to start thinking about having a little drop-down menu that says, oh, they're angry, they're hostile, they're in denial, what's going on with that patient. Caregiver emotions, that husband, that wife, that significant other is interfering with that plan or is causing more problems than help. Okay? Evidence of disclosure of a sentinel event. That requires either discussion or reporting or integrating or getting that sentinel event occurred. The use of play it or adaptive equipment. Devices, not just an interpreter or translator, but some device. So all of those kiddos that are getting play therapy would be. So one of my social workers who works in an agency said, so I'm using interactive complexity all the time, correctly, because it's documented. And she noticed that the physician who's also seeing this patient, who does some psychotherapy from time to time, has never coded interactive complexity ever, and it's the same patient. As a matter of fact, the patient has the same issues with the physician that they have with the other therapists. So one of the processes that you need to begin thinking about is continuity in this area. My guy last night who asked about the Suboxone patient and the interactive complexity on that visit he had yesterday, he said, is this patient going to be interactively complex for the rest of the time with me? And my answer was, only if he's bringing in Jim, at every visit, or you're coordinating with Jim at every visit, would you be? He said, okay. Because the plan was to bring Jim in for one more visit and then based on need. So sometimes interactive complexity on the same patient might not be for every visit. It might be based on what's going on that day. If all of a sudden I come in for a visit and I've been doing real well, but today I'm in denial, angry, upset, volatile pacing, I might be interactively complex because I'm no longer taking my medication. And then the next time I come back, I'm good. I've been taking my medication. I'm responding. So interactive complexity for some of your caseload may be event-specific. Others, like in children or in some communication issues, may be across the board. But we have to make sure that we have a documentation process to make sure it's clearly noted. High anxiety, reactivity, repeated questions, inability to comprehend, disagreement, denial, argumentative. This was actually my entire life as a social worker way back when. And some of you may say, oh, this is like, and it is. In an agency level, it is often a high percentage of your patients, depending on what's happening. Okay? The use of supports in communication, that might be, as I said, play therapy, some kind of communication tool. The one CNS, she had a beautiful note, and the patient was very regressed in a particular visit, and normally is communicative. But in this particular visit, because of what was going on at home, the entire session took place by writing notes. said that session was interactively complex, and that was right. And so she created a little drop-down menu that said this was complex because of. Today, Mary Beth was not able to communicate. It was all by writing or all by hand signals, whatever it might be. So remember that, that process has to be in place. Examples, court ordered. Okay. During the initial assessment, the bipolar or manic tendencies, the patient's unable to verbally communicate or without supports, without process. During therapy, the spouse is in denial about the severity of the addiction or process and is interfering with that treatment plan. Now, interactive complexity can be coded, as I said, with psychotherapy, with E&M or without. It can also be coded in group therapy, so that if that patient and maybe the entire group are interactively complex because they're children and we're doing play therapy. But you may have a group of adults where one of them in an anger management group is totally volatile that day. And maybe they leave at one point. So it may not be for every patient in group therapy based on what the group is and how the interaction goes. But interactive complexity can be used in group therapy either for all the participants if they all have that meet criteria that has to be documented, or just for one or two of them that are having whatever issues there may be. So remember, it's not added with E&M alone, and it's not added with family therapy. Disclosure of a sentinel event. So that would mean, child abuse, elder abuse, self-harm, suicidal, homicidal, and that would require the documentation of what that event was and what that coordination and plan might be. It does not necessarily require you notifying the police or authorities. It is whatever is appropriate in that situation or scenario. It might be if someone's thinking self-harm, that coordination with the family to make sure that weapons are secure, there's no guns, whatever it might be. So that documentation would need to show up. And this is where I remind you that I'm making sure that that diagnosis is there. If one of the reasons why they're having interactive complexity is because of a stroke 5 years ago, or they have their spinal cord and injury and they are not able to communicate, then that diagnosis has to be part of that assessment process. So I might have some scenarios where I would be having a medical diagnosis that supports that interactive complexity. Other times it might just be my drug dependency or my hallucinations or whatever else. Time involved with interactive complexity. Remember I said it's a state of being. So if you're coding just an evaluation and management and can't add that interactive complexity, this state of being probably makes me a higher level care patient already, as long as I've documented in that note that they're volatile, they're angry, they're in denial, they're non-compliant. And that's not a simple 99213. That moves up to the ladder to higher levels based on what you're doing with that process. So that when all you're doing is an E&M service, because they're maybe not amenable to therapy, then whatever that state of being is, if it's a communication issue that they're not able to communicate and your visit's taking longer because you're having to use a piece of paper, then that needs to be documented, and that may support higher levels of visit based on what's happening. If that visit and the family member is there and asking a zillion questions over and over and over again, and instead of being the scheduled 20-minute visit, you're now 40 minutes because you're counseling and educating a family member, then that would be coded as a visit based on time. So even though the state of being can only be coded as interactive complexity with therapy, it is important to make sure you include it because that's going to change your level of care when we're talking only about evaluation and management services. So my template, and each one of you may have different things that make a patient interactively complex. And so on a handwritten note, you may want to come up with a couple different scenarios for your providers to check and identify. In EMR, you might create drop-down menus that say why I'm interactively complex, what your most common things are over and over and over again. My one program has 3 options. Court issues, behavioral issues and familial issues, and then they expound on what they might be. Okay. Does this support interactive complexity? My assessment and coordination with parents and school treatment plan. Sure, because it's a 5-year-old, right? Or a 10-year-old or a 15-year-old, or any age if they're coordinating that process. An elderly gentleman who requires an interpreter alone? Nope. Nope. My woman involved in therapy and coordination of services through a court system. She's very anxious and scared. Yeah. Okay. The last one, the patient with an outside caseworker involved who is coordinating care and services. It should be, but we have to identify what those care and services are. Okay? So making sure that we identify what they are is what makes it interactively complex. And so when I have somebody just say, coordinating with caseworker, I've got to say what you're coordinating.